Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted yet so profoundly impactful.
Hello, everyone, and welcome back to Muted in Medicine, the podcast where we talk about the things healthcare often keeps quiet so we can bring them into the light. My name is Saba Fatima, and I'm your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare. Today's episode is a special one. I'm joined by Dr. W.Wu, a physician, researcher, and thought leader whose work has changed the way we understand the emotional impact of practicing medicine. Over 2 decades ago, he coined the term second victim to describe the distress that healthcare workers experience after being involved in a medical error or adverse event. A concept that gave language to something many had felt, but few had spoken about. Medical errors are more common than we like to admit. They remain one of healthcare's most hidden and most painful realities. And for the providers involved, the emotional fallout can include guilt, shame, isolation, and even long-term trauma. In this conversation, we explore what second victim syndrome really means, how healthcare systems have responded, and whether the term still fits today. We also dive into an important tension. How do we prioritize patient safety while also making space for compassion and care for the provider? Can we create systems where accountability doesn't come at the cost of a clinician's mental health? This is a conversation about grief, healing, culture change, and the quiet injuries that too many carry alone. I'm joined by Dr. W.Wu, who's a practicing general internist and Fred and Juliet Soper Professor of Health Policy and Management, with joint appointments in epidemiology, international health, medicine, surgery, and business at Johns Hopkins University. He's director of the Center for Health Services and Outcomes Research and PhD in Health Services Research. He has worked in patient safety since the 1988. He was senior advisor for patient safety at WHO from 2007 and 2009 and continues with this work. He's director of strategic collaborations for the Armstrong Institute, leads the online Masters of Applied Science in Patient Safety and Healthcare Quality, and is editor-in-chief of the Journal of Patient Safety and Risk Management. He coined the term second victim and is co-founder and co-director of RISE, Resilience in Stressful Events Peer Support Program. Dr. Wu, what an honor. Welcome to the show.
Oh, thank you so much, Saba. I'm really pleased to be here, and I love the concept of muted in medicine. I think that there are many secrets in medicine, but many of them we also keep to ourselves or keep from ourselves and really never, ever talk about them. So I'm really happy to be here.
Thank you. And we ask everybody when we start, what is bringing you joy in medicine today, Dr. Wu, you think?
I think that the thing that brings me joy in medicine, even when there are frustrations outside of medicine with all of the extra things that we now do, when I'm frustrated by my electronic health record, which is perhaps the bane of my existence, when I actually get into the clinic and see patients, some of whom I've taken care of for decades, that makes me happy.
Yeah, absolutely. I think patient care is the number one thing that most providers said they enjoy when we talk to them. Let me tell you, I'm a huge fan. I would say this term second victim helped me when I was going through something. And I know you coined it over 2 decades ago. Can you take us back to what prompted you to use that term and what kind of response it received at that time?
So you mentioned you had an event, but the fact is that we all do, because if you take care of patients, there's always something.
Yeah.
I was, like all of us, was aware of this, but never talked about it. I had my own personal experiences. I witnessed things happen when I began to supervise other physicians. And it finally occurred to me that this is something that should be written about. I was invited by Lucian Leap and Don Berwick, who are both legends in patient safety, to write about this in the British Medical Journal's special issue on patient safety in 2000, and just wrote a
Yeah.
small piece about medical error, the second victim.
Yeah, I remember that. The doctor who makes the mistakes needs help too. Like that was that the piece? Yeah.
Yeah, absolutely. And it was just it was really a commentary, but
Yeah.
it really seemed to catch on quickly. I got a lot of email and messages and even written messages from clinicians who expressed gratitude that their experience was finally being recognized as something that was real. They felt validated and they felt comforted to know that it wasn't just them, which we all suspect, because we have such a pathologic relationship with our ability to fail, with our fallibility. They took comfort that they were not alone. They were not the only clinician, the only bad doctor out there who had made an error.
Yeah. No, I mean, I think it's just amazing work. But the matter of the fact is, I think some listeners still might not know what second victim is because, again, we're still it's so hard to talk about still. So I don't know if you would, I know it's probably repetitive, but tell people about what is just second victim syndrome and how is it different from just general stress or burnout? Because I want to hear it from you.
Yeah. I mean, I think that sort of the term refers to someone taking care of patients who experiences emotional distress, perhaps even trauma, after one of their patients experiences an adverse event, perhaps due to an error in care. They are essentially traumatized by the same incidents that harm patients.
Yeah.
And they might feel that they were victims also. They might feel that they were put in a bad position. They were set up by the flaws that exist in the system. Those systems harm patients, and because they were the closest to the patient, perhaps they made a decision, or they were part of a system that inevitably causes harm, that they were also themselves victims.
Yeah. And it can be pretty serious. So I know from personal experience when you feel that trauma, the doctors can take a lot of personal responsibility, shame, and you've done so much research over time. Is that something that you've seen in doctors that it can be pretty serious? It's just not like a one-time event, right?
It is, and we tend to take things very hard. We sort of go into medicine believing that we can do good,
Yeah.
and we believe, and I think legitimately, that we do good at least a lot of the time. But we also tend to take perhaps more responsibility than is even justified sometimes when things go wrong. Even if you've done everything correct, but the patient has a bad outcome, or even if you've been involved in some patient care which was grueling and difficult and traumatic, and the patient does okay, you can still be shaken by that.
Yeah.
And we naturally tend to feel shame and guilt, and just feel terrible about ourselves. And we put a lot of stake in our competence. And when
Yeah.
something goes wrong because we've been indoctrinated, that
Yeah.
we should not do harm. We should only do good. We feel there's something wrong with us. Maybe we're not competent or no longer competent. Maybe we should be doing something else. We really can have serious doubts when these things happen.
Yeah. And some people, I've read some papers, they argued that the term second victim, it minimizes the harm experienced by the patients and families. And how had you responded to that? And do you think the term still stands today?
Yeah, there are some patients and some patient advocates who believe that this takes away the focus from the patient.
Yeah.
I think that those individuals, while they're fully justified in their feelings, just like us, just like doctors, do not understand that it really is the system that causes benefit and that can cause harm.
Yeah.
And so they don't, I think that some of them feel like they themselves were truly victims. But
Yeah.
in most cases, those were people who were honestly treated badly by the system. In some cases, I've talked to many of them, they were frankly abused by the system and even by individual practitioners. This is rare, but it does happen. And they'll say, I could never think of that person, that perpetrator who harmed me. I could never think of that person as a victim. And so I understand that. On the other hand, because this is such a universal experience, and perhaps because no one has managed to come up with a better term that captures the feeling, I think the term is still relevant.
And I agree. I mean, I do agree that you work in patient safety. So I think you work in creating better systems, right? Safe systems. And how do you create that balance? Like, so how are you working in both patient safety and helping providers cope through this? How do you balance those two?
Yeah, I think this is a false dichotomy.
Yeah.
I think that you need physician or you need clinician wellness to have good quality care.
Yeah.
And so I think that the supporting health workers and supporting patients are really two sides of the same coin. Honestly, I don't think you could have one without the other.
Yeah. Yeah. That if you have providers who are well, they can take better care of patients. That's a fair point.
And it's not just that they'll give safer care. It's not just that physicians who have greater well-being, who have less stress or who experience less stress will give safer care.
Yeah.
But I think they will really give better care. It's not just that we want to be taken care of by someone who's not unwell.
Yeah.
We don't want to be taken care of by someone who is mentally unfit, but we would really like to take care of someone who's very well, who's feeling healthy, well-rested, confident, optimistic, who has the emotional reserves to be as kind as they possibly could and as caring, to be their best selves. We would like to be taken care of by those people, and we would like to be those people. I think health systems are coming to this conclusion a bit late.
Yeah. And I was just going to say, how do you do that, right? Like, so I still feel like you wrote that paper in 2025. There's still a lot of shame and trauma and things that we are afraid to talk about in the open. So how do we do that? Like, how do we create systems that support healthcare providers?
Yeah, I think it's hard. I think that shame and blame are things that humans do.
Yeah.
And we naturally resort to them when things go wrong. That's something that preceded healthcare even.
Yeah.
And so we need to realize that this is not helpful. In fact, it's maladaptive. We
Yeah.
need to understand that this is a normal response, but we need to work to create a system that supports health workers so they can support patients.
Right. What are your thoughts on, after an error happens, obviously a lot of error or adverse event happens, what could help a provider in the immediate, aftermath of it, or later, what could help?
Question. I mean, Ideally, we talk a lot about resilience. Ideally, we would like people to be resilient so they can maintain their well-being even when they are stressed.
Yeah.
But we put a lot of responsibility for being resilient on the individual.
Right.
And it's the responsibility of organizations, of institutions, to provide support also. So I think that
Right.
resilience is not just an individual characteristic, but it's a system necessity.
Yeah.
When someone experiences a really traumatic event or a very distressing event, they need support. I think realizing that is the first really important lesson. It is not a weakness to ask for help or seek support. It's a strength. Recognize that you need it so that you can be resilient, you can recover. Sometimes things are so difficult that you need outside help to really recover and get back to your own internal mechanisms. So
Yeah.
I think the thing to do really is to seek support, to seek social support. If there's one thing to do, I think that would be the solution.
What do you think about apologizing to patients and disclosure? Because I know you've done some research on that too. Like for providers, what is a safe way to do it? And is apology really helpful to protect them from harm?
I think apologizing is also difficult. Again, I think that humans, are not inclined to disclose their shortcomings.
Right.
That's true for people outside of the hospital who are not clinicians, and
Right.
it's true for doctors and other providers too. It's really
Right.
difficult. I think that this is part of understanding that that safety is an issue, and I think that disclosing on sort of a system level to help people understand what healthcare is about, I think it's important. But what's more important, I think, is to understand that patients need to know. They have a right to know, and they are relieved to know when something goes wrong, what the causes were. And
Yeah.
so explaining or disclosing an adverse event is really important for the patient. It's maybe it helps the doctor appreciate for themselves that these things happen and that they're not all aberrations in care, that they're not something to be ashamed of.
Yeah.
But also apologizing is, again, something that people need. And I think apologizing is easy. We're just not used to doing it. There's always an appropriate apology. If someone's cat dies, you can say, "I'm so sorry that your cat passed away.
Yeah.
I know they were important to you, even
Yeah.
if you had nothing to do with the death of that
Yeah.
pet." But
Yeah.
if something happens in the hospital, you can say, "I'm sorry that happened."
Yeah.
If you did something, you could say, "I'm sorry that I did this."
Yeah. And it's interesting. So I had a trainee just yesterday, and I think it was not it was some sort of a diagnostic process that maybe went wrong last time they were here. So it wasn't really a mistake, but just a process. And the trainee, I think they were overcritical, and they went to the family and they said, we messed up as a team. Just because I think maybe they were feeling that internal shame. I'm not sure. So I agree that we should disclose, but can we protect harm to ourselves, or it's the right thing to do and we need to do that?
Yeah, I think it's the right thing to do. You can be trained to disclose in an appropriate way, perhaps not to take too much credit for things going wrong,
Right.
not to take which in many cases is incorrect. It's not actually the truth.
Right.
But I think that there shouldn't be one truth among clinicians and then one truth that we share with the patients.
Right.
I think that we should, if we talk so much about transparency and honesty, but we should
Yes.
tell them what happened. We can explain that it was not, that this is sometimes just the way things were. That you might have had some responsibility personally, but again, I think that you shouldn't take credit for things that didn't happen.
Yeah. Okay. Yeah, I agree with that. When you talk about shame, what do you think about peer review meetings and morbidity and mortality meetings? Do you think they help the clinician or the patient and are good practices?
I think they're good practices. I think the way they're conducted is not always good. I think that even though we've tried to improve the practice of M&M, I think they can still seem very punitive.
Yeah.
And people who are presenting their cases can experience them as being very punitive. We have actually begun to provide support at debriefings or at M&M conferences because it's hard to train people out of being critical. You might not be being accusatory, but you may still be, you may still offer a criticism. And when people are presented with that, they can benefit from having some support.
Yeah. So tell me more about that. Yeah, I know you have the RISE program at Johns Hopkins. How did that come about? And is it helpful to clinicians still active right now?
Yeah. So the RISE program came out of the realization that when things go wrong and these things happen in the hospital, these things happen every day. Fortunately, not to every clinician every day. But we surveyed people, several hundred people early in the patient safety era, and all of them said what they really wanted was a prompt opportunity to speak to someone and be supported. So we created this team in about 2010 or 2011.
Mm-hmm.
It is a group of volunteer hospital workers who really are peers because they understand what it's like to work in the hospital. They understand the stresses and the risks to clinicians. They are on call 24 hours a day, 7 days a week. And if someone feels overly stressed, if they experience something truly traumatic, they call. Someone calls them back. The goal is to call back within half an hour. And they arrange to talk or to meet individually or as a group. And and the peer responder provides what's really psychological first aid. It's not counseling. It's not therapy. It's empathic listening and support. It's become a really, I think that over the years, initially no one called because they didn't know about it and they were afraid to. This year, we are on track at Johns Hopkins Hospital alone to talk to and support maybe 2,000 or 2,500 healthcare workers.
Wow. Okay.
All of these calls are not about mistakes. In fact, 90% of them are not about even patient harm. But there are many disappointing and difficult things that happen in healthcare. People are there. They may be taking care of the patient directly. They may actually make a mistake occasionally. But when someone is harmed, there are always second victims. And they might not be clinicians. They might be someone in food service or in patient transport or a cleaner or a security person who interact with patients and also can feel that.
Yeah. No, that's amazing. So you have how many trained peer supporters do you have? And you said they're on call 24/7. Like, that's pretty amazing.
We have a team of about between 20 and 30 people who are trained in delivering sort of the RISE intervention, which is really peer support.
Yeah.
And psychological first aid. We've trained over 1,000 people in the institution so that people are familiar with the techniques and are more willing to refer when there's need. If they see it, for example, on a nursing unit, the majority of our calls come from unit directors who see that something happened on their unit. People feel badly and could benefit from support.
Yeah. But they would have to, they refer a person who'd be willing to talk. So it's voluntary, I'm assuming.
So what they do is they actually encourage, they may call, but then they encourage, in most cases, they encourage the person who would benefit from, they encourage them to call. It can be done very, very quickly. There are QR codes on badges and all over the hospital, so people can just call someone on their phone by shooting the QR code. When there are large and splashy and horrible events, we may arrange to show up. If there's a messy code on a unit, we may arrange for a few of us to go over and pay a visit and ask people how they're doing.
Yeah, that's awesome. And then is there follow-up too, or is just that one and done?
There is no organized follow-up. We tell people that if they still need to or feel like they would like to talk to someone, that they can always call again.
Yeah.
In general, people rarely call. In fact, in a very small percentage of cases, call again. But
Yeah.
we're not their therapists. We're really
Yeah.
just there to do first aid, to pick them up, to help them get back to their feet, and let their own natural mechanisms of self-support, of resilience kick in.
Yeah. No, that's awesome. And so what have you learned just the process-wise from running a program like RISE? Because it sounds amazing, but I would say what could be done in like smaller hospital systems who don't have, I think, that sort of infrastructure or resources. Do you have any ideas or suggestions?
Well, first of all, we think everyone should have RISE.
Okay.
We've now trained 150 hospitals around the country,
Yeah.
and more every day. They're also in Canada and in Northern Europe and in the Middle East.
Yeah.
So this is something that is catching on.
Yeah.
But people should understand the principles of psychological first aid. We
Yeah.
feel like this should be the next CPR training, that everyone
Right.
should be able to support themselves and their colleagues when things go wrong. So I think that is maybe that's the next attempt to further democratize the system.
Okay. Yeah. And if you don't mind, do you mind telling us briefly, like based on what you've done? I know the RISE is a full training, but what is the basic principle maybe of psychological first aid when somebody is going through such a traumatic event? What do they need in that moment? You said just somebody to talk to.
Well, some of the basic principles are, and psychological first aid was developed in part by the World Health Organization for dealing with natural disasters,
Right.
maybe earthquakes or maybe pandemics.
Right.
But psychological first aid is based primarily on a few principles. One is showing up. The
Mm.
second is being present and listening without judgment.
Mm.
Being empathetic and providing emotional support.
Yeah.
It's not any kind of analysis. It's not
Yeah.
therapy. It's not offering solutions and trying to fix problems which could not be fixed mostly in a half hour or 45-minute encounter.
Yeah.
That's most of what's involved.
Just showing up. Yeah. When you speak with patients or when you've seen adverse events happen to patients, I'm just curious, do you think there's we talked about this earlier, but disconnect between the provider and the patient? I think the patients don't know that the providers how bad they feel or that they also are traumatized by it in that sense that they're sorry or apologetic. And is there a thing that we can do to bridge that disconnect? Because sometimes I feel like, when litigation or lawsuits and things like these happen, it's just because sometimes it's because maybe not of good communication. Patients feel that the provider didn't care almost. And I'm just curious, do you think that there's a disconnect and how can that be bridged?
I think the disconnect is really at the system level. I think that we all conspire together to pretend that errors never happen.
Right.
And everyone would like to believe this.
Yeah.
Many hospitals do not have systems for disclosure, for supporting health workers, for making sure that health workers are treated fairly, and even for dealing with lawsuits when they occur in a way that is the most convenient and the most helpful to the patient who may
Yeah.
have occasionally, been the recipient of care that could have been better. I think that peer support and RISE and supporting second victims is very important because it gives workers greater confidence that they are being supported by their institutions.
Right.
But I think that this is only part of a greater culture that respects both well-being and fairness to patients. Some people
Yes.
call this just culture.
Right.
There's a movement called candor, which relates to being more accountable, more
Yeah.
transparent, and more accountable with patients. And I think this is all part of a real culture shift that is necessary in American medicine and in healthcare in general, that sort of acknowledges that there are people, sort of healthcare is really humans taking care of other humans. And people need to be aware of this, and with that understanding, they can better appreciate what happens.
And when you talk about being more accountable towards patients, I mean, what would that mean? Because I feel like the trauma that they go through, it's just sometimes unexplainable and there's a lot of shame. So I'm just curious, how can you be more accountable towards patients? How can we do that better? I want to hear like the patient perspective a little bit on with your work on patient safety.
Yeah, I mean, I think that we are pushing for greater transparency and accountability that is communicated to patients before things go wrong and after things go wrong, and perhaps even during when something is an ongoing situation. I spoke earlier about the fact that there should only be one truth or one record. We shouldn't write one thing in the chart and say another thing to our colleagues and then say another thing to the patient. It should all be the same thing. It's what we're doing, and if we're not honest about it, I think that patients will feel like we're not being honest, we're not trustworthy, and we're not.
And so just communication is key. If the culture from the year 2000, 2025 now, do you think you've seen significant change in support of healthcare workers, or do you think there's still a lot of work to be done?
I think there has been change. I think it's been gradual. I think, like all things, it's the distribution of uptake of these ideas is uneven. So some organizations are quite advanced and others have not moved an inch since 2020. But there are many more hospitals. Certainly every academic medical center has a wellness coordinator. And that is a worker wellness coordinator or some sort of entity to try to make the work of workers just a little bit easier. If people are not supported, there's at increased risk for burnout, which is really at epidemic proportions in U.S. hospitals and actually hospitals around the world. And as a result, those clinicians, people who are burnt out, either take time off, or they show up and drag everything down, or they're just resentful. People talk about absenteeism and presenteeism and even resenteeism. And those are all problems when workers are not taken care of by their organizations. There's actually some important research by Brian Sexton at Duke, who found that when workers feel like second victims are supported by their institution, then they have greater trust, feel better in their work, and have fewer adverse outcomes.
Yeah. And in your work with second victims, if you've seen that if they're not supported, what can happen if they are not supported for a long time? Do you think a lot of providers can leave the profession?
So I think that when people aren't supported, they suffer more than they would have otherwise. I think that a rapid intervention, or I think that supporting someone as things are happening can help them understand that it's not all their fault, that they're not the only ones who've ever done this, that that they shouldn't bear sole responsibility. They can reframe things, and so that they are less likely to develop sequela, really long-standing, persistent symptoms of depression and lack of self-esteem and anxiety and fear. Those people, first of all, are less likely to are less likely to deliver good care, but they may develop burnouts. They may develop post-traumatic stress disorder in some cases. Some of them move out of the institution to find a friendlier one. Some people occasionally leave the profession, and this happens more for nurses than for anyone, I think. So I think there are real reverberations. In the worst cases, health workers commit suicide or healthcare workers die by suicide at a higher rate than the normal population. And perhaps the scale of things that we experience is magnified, but that is something which is a real tragedy.
And you said something in the initial that we have a pathologic relationship with infallibility. What do you feel about the concept that you should be tough enough, to face this if you're a healthcare worker in this profession? Do you think that stands true or no?
Yeah, I mean, I think that we should learn what the job is about. And
Yeah.
it is true that we need to be resilient. At Hopkins, there's an expression which in the medical service, on the Ulster Medical Service, of equanimitas. You must maintain equanimity at all times in caring for patients, because if you're
Yeah.
falling apart, you won't do a good job.
Right.
I think that is true, but I think it's incomplete. I think
Yeah.
in the short term, that is true. I think in the longer term, if we don't acknowledge that human caregivers are human and can therefore be fallible,
Yeah.
they will make mistakes. They will encounter traumatic situations. If we
Yeah.
don't support them, if we don't acknowledge the fact that it is humans taking care of other humans, then we will not be as successful.
Yeah.
I
It's
mean,
just
we
important.
won't be so successful at delivering our mission to take the best care of patients.
Right. And it's just a very important reminder. And I'm glad you're saying that again and again. Humans are humans. Just the reminder that we are humans in this profession. I want to know, what advice would you give, just on a personal level, having done this work for so long, to healthcare providers who have been through a traumatic event? Just your personal advice to them.
Yeah, I would say that healthcare is a high risk industry.
Yeah.
We don't think of it that way, but we are exposed every day to extraordinary stresses, which go beyond the normal experience of most people. Feeling badly, encountering tragedy, and being distressed about things that happen around us, or
Yeah.
even that things that we're responsible for. It's a natural response. We would hope that people would feel badly when things go wrong, when patients have outcomes that we would prefer not to see, when people die, when people suffer. We need to understand that those things go with the job. So it's a strength to seek support. We are
Yeah.
stronger together. You should seek support when you need it. You should seek help when you need it.
Yeah.
I would say you are not alone.
Yeah. It's an important message. Yeah. And do you have any message for the leaders of the hospital systems who are trying to develop systems, or maybe just not doing a good job at it?
Yeah, I would say that if you are a leader, this is an important goal of healthcare. Your institution will not succeed as to its potential if you neglect this area. You need
Yeah.
to appreciate that your healthcare workers are your greatest assets. It allows your institution to live up to its reputation. But
Yeah.
if you do not support them, if you do not take active steps to support them, you will not succeed as much as you can. It's important in particular to arrange supports at an
Yeah.
organizational level, and to be able to appreciate that things will go wrong. This is just a verity of healthcare, and to be able to listen without judgment and be supportive when you hear things going wrong.
Is there any more exciting stuff that you're working on with RISE, or something that's changing, or just in the culture for patient safety that we'd like to listen to or know about?
Yeah, I think that we realize that RISE is not the whole solution.
Hmm.
I think it's just part of a change, a gradual change, but a shift in the culture of healthcare. We
Yeah.
need to educate people about the way things really are.
Yeah.
And so that they are aware that this is a potential problem that they can do something about.
Yeah.
Something that we're doing that we've added recently is a what we call a restorative space, the Rise restorative space, and we've created a multi-room place for workers to sign up to get a little bit of respite from a massage chair or a tune bed or an arts and crafts station or a music room
I
or a
love that.
quiet room with
Yeah.
biophilic features. Thousands of our workers are signing up to
Oh,
take advantage of this. We're
mm,
also working closely with all of the other helping and supportive structures that exist in the health system. We have a system which we call MESH,
mm,
which is mental, emotional, and spiritual health.
yeah. Yeah.
And we meet regularly. For a while, we were meeting twice a week during the pandemic, but now we meet at least a couple of times a month
Yeah.
to pull together employee assistance, our wellness program, Rise, our chaplains, and for that matter, our Department of Psychiatry, so that we can offer and coordinate all of those services, all of which are necessary.
Yeah. And it reminds me the peer supporters are not just clinicians, right? They're chaplains or other people.
No, our peer supporters. I think the majority might be nurses. There are a few physicians, but there are also social workers, psychiatric social workers, chaplains, and then many others, pharmacists, EMTs. There was someone who was a phlebotomist.
Mm,
But these are all people who others naturally gravitate to.
yeah.
Even if there was no structure, they would go to those people and to talk to. And so those are the people who volunteer and are trained to be Rise responders. Some of them have been on the team ever since we started in 2012.
Wow. That's awesome. Yeah. I think we're going towards the end. Just one of the last questions I had since you wrote that paper. Do you think differently about second victims today, like 25 years later?
I do. I realize that it's not all about errors. There are a range of experiences that we are exposed to or could be exposed to really every day that we are in the hospital delivering care.
Right.
And many of those things can cause distress, which
Yeah.
is absolutely normal. So we need to be more attuned to that, not be thinking about this as medical errors. We should be thinking about this as the well-being and resilience of workers.
Yeah.
What can we do at ourselves? What can we do at an individual level or dealing with our colleagues at work? And what
Yeah.
systems should be arranged? I think
Yeah.
that if we keep that in mind, we will we'll move ahead much faster.
As we wrap up this conversation, usually there's a tradition on the podcast. I leave you with a poem that's simple but powerful. It's not about medicine, but it speaks to something many of us in healthcare quietly carry, the fear of not being enough after something goes wrong. This is Thinking by Walter D. Vinto. It's a reminder that battles we face in medicine, especially after an error, often begin and are healed from within. So it's a very simple poem. You probably heard it before. If you think you're beaten, you are. If you think you dare not, you don't. If you'd like to win but you think you can't, it's almost a cinch you won't. If you think you'll lose, you're lost. For out on the world we find, success begins with a fellow's will. It's all in the state of mind. If you think you're outclassed, you are. You've got to think high to rise. You've got to be sure of yourself before you can ever win a prize. Life's battles don't always go to the stronger or faster man, but sooner or later, the man who wins is the one who thinks he can. Thank you, Dr. Wu, for doing this with us today. Really, I'm a huge fan of your work, and I'm so grateful for this opportunity.
Well, thank you for the chance to talk to you and to your audience.